June.
Now, welcome to our next session on challenges in management of sexually transmitted infections, current scenario. For this session, let me introduce to you the moderator, Dr. Shubhamoy Niyogi, MBBS, MD, Dermatology, Venereology and Leprosy. Currently, Dr. Niyogi is the clinical tutor at IPGMER SSKM Hospital. His special area of interests are clinical and procedural dermatology. Now, I request Dr. Niyogi to carry on the session forward. Yes.
So I would like to request Dr. Sujata Madam and to start the session. And at first I'd like to introduce her. She is a professor and HOD KPC Medical College and Hospital, Kolkata. She has multiple publications to her name, and she has also received multiple awards. Her special areas of interest are clinical dermatology and female genital dermatosis. So I would like to hand over the session to Dr. Sujata Sengupta. Over to you, ma'am.
Thank you, Dr. Shubhamoy, for the kind introduction. I would now like to share my screen. Just give me a few moments. Is it visible to everyone? Is my screen visible? Is my screen visible?
Yes, ma'am, you are visible.
Okay. I would like to thank the organizing committee of MidQTCon for giving me the opportunity to present my topic. Here is challenges in management of STIs, current scenario. Sexually transmitted infections and reproductive tract infections are a major public health problem worldwide, causing a poor quality of life and serious morbidity and mortality. The STIs are actually a part of the reproductive tract infection and consist of bacterial, viral, and parasitic infections. The impact of STIs have a direct impact and an indirect impact. Direct effect on reproductive and child health through infertility, cancers, and pregnancy complications. Indirect effect by the role on facilitating sexual transmission of HIV. Impact on individual and national economy, and poor quality of life with increased morbidity and mortality. Worldwide, the burden of infection depends on the gender and the region and is more in resource-poor countries. 2/3 of all cases occur in adolescents and young adults, and there are more than 1 million curable STIs acquired every day. The 2012 figures show 357 million new cases in the 15 to 49 age group, with chlamydia 131 million, gonorrhea 78 million, syphilis 6 million, and trichomoniasis 142 million. The viral STDs do not remain behind, with 417 million with HSV2 and 291 million women harbored human papilloma virus. Back home in India, every year, 6% of the adult population is infected with STIs. 30 to 35 million episodes of STIs are treated every year. The National AIDS Control Organization reported treating 3.9 million STI cases between 2016 and 17. We had 23.5 lakh people living with AIDS in 2019. The estimated new annual HIV infection as of 2019 is more than 69,000, of which 12% were less than 15 years of age. This is an analysis of multiple studies which show the changing trends of STD in India. We see the syphilis, gonorrhea, and chancroid, the bacterial infections have drastically come down, while there has been an increase in condyloma acuminata, genital herpes, and balanoposthitis, which shows that fungal and viral STDs are now taking over. The management of STI has generally been on two pillars. One is the behavioral and biomedical primary prevention to prevent STD acquisition by uninfected persons. And the other one is the diagnosis and management of infected people to prevent STI complications and stop ongoing transmission. These are the level of preventions that we have had in place for a long time. Primary prevention, creating awareness, advice on safer sex, correct condom use, avoiding multiple partners, removing community bias, and access to safe delivery and abortion, and screening every pregnant lady for syphilis. Secondary prevention says early diagnosis and proper treatment. And of course, partner management is a very important part of secondary prevention. Accessible and affordable STI and RTI services in the locality is very important. Tertiary prevention is prevention of the late complications and complications of infertility and in children. The common challenges that we have faced are the lack of knowledge about the STI risks, misconceptions, and the absence of signs and symptoms in women. There are two at-risk groups which have been very difficult to control. One is the sexually active adolescents having unsafe sex, and the group with men having sex with men, including the transgenders. So this cycle usually starts with risky sexual behaviors and unprotected sex. And then AIDS was diagnosed in MSMs with multiple STIs in 1980. This was followed by the HIV epidemic, and people were forced to stick to the safe sexual practices. But in 1996, with the arrival of the antiretroviral therapy, the world was shown that HIV is no longer a life-threatening disease. After that, with options such as pre and post-exposure prophylaxis and treatment as prevention options, a phenomenon called treatment optimism occurred, and this led to an increase in the risky sexual behaviors and unprotected sex against. So the availability of the ART posed a paradoxical challenge in the prevention of STIs. The Payot-Cranston model is a very nice model which depicts the problems that we encounter with STI management. The lower bar shows 100 women with RTI, and ultimately when we go upwards, only 1 to 5% of these patients actually receive effective treatment and their partner management. So what we see as we go above, the loss of the length of the bar every time is actually a missed opportunity in stopping the transmission of the disease as well as effective control. The common problems like lack of knowledge, reluctance to discuss sexual matters, fear of judgmental approach by the healthcare workers, this we must take note of, and dependence of home remedies, quacks, and faith healers. Etiological approach has been unavailable in the developing countries. It requires multiple visits by the patient and is expensive, and syndromic approach that we have been using so long is not useful in low STI prevalence. There's a cost of overdiagnosis. There are risks of drug reactions, resistance, and alteration in the gut flora, and poor sensitivity and specificity in cervical infections. In 2017, the Lancet Infectious Disease Commission has identified 5 points of current challenge in STI management globally. The first 3 parts include chlamydia, Neisseria, and bacterial vaginosis. The part 4 deals with the challenges in STI control in the low and middle income group countries. And the part 5 is about epidemics of STIs in men having sex with men population in high income groups. The global burden of chlamydia-related PID, infertility, and pregnancy complications is very high. In low-income countries where no lab facilities are available, infections are missed, and in developed countries, proportion of women who are screened remains very low. The widespread use of a single dose of azithromycin has been questioned, and according to WHO's Global Health Sector Strategy on STIs, further research and cost-effective analysis is necessary to control chlamydia. Coming to Neisseria, it forms a major burden of global gonorrhea in the low and middle income group countries. Complications include PID, ectopic pregnancy, infertility, and facilitation of HIV transmission. While several countries have already reported resistance to multiple antibiotics, now we are faced with the problem of gonorrhea threatened by rising resistance to ceftriaxone. Dual antimicrobial therapy with ceftriaxone azithromycin is currently the only option. Oral cefixime can be tried. A new hope in the horizon is a new antimicrobial showing in vitro activity like avorafloxacin, delafloxacin, and citalfloxacin, group of fluoroquinolones, and macrolides like morithromycin. But a phase 3 RCT to evaluate delafloxacin showed that it was ineffective as
Still
monotherapy. Novel antimicrobials in trial are solithromycin, soliflodacin, and gepotidacin. Bacterial vaginosis continues to remain a conundrum because no sole pathogenic organism has been identified yet, and there is no obvious disease counterpart in the male. So the general consensus remains that BV is not sexually transmitted, though it is associated with twice the risk of acquiring other STIs and increased risk of HIV transmission to male partners, along with all the other pregnancy complications. It is notorious for biofilm formation, and the only treatment that we have for the destruction of that is octinidyl and boric acid and probiotics as a replenishment for the loss of the lactobacillus. Challenges in the low and middle income countries like India, this is the main focus of the lecture. 90% of new STIs were reported from developing countries in 2012. Though primary prevention has shown some favorable changes, secondary prevention and STI case management has been hampered by the lack of affordable and accessible care. Point of care tests developed by WHO are important gaps in STI care. However, these point of care tests away from the laboratories can actually pressurize the fragile health system in terms of supply and training, quality assurance, and manpower. Syndromic management that we have been using so long has poor specificity, especially in chlamydia and gonorrhea, and results in overtreatment. Partner notification is a huge challenge in case of Indian women, especially where, and we need to minimize the risk of abuse and rejection in them when they are involved in partner notification. Emerging STIs are LGV and hepatitis C, and unusual outbreaks have occurred in HIV patients, especially men having sex with men. Mycoplasma genitalium associated with urethritis in men has showed rapid emergence of resistance. In 2017, a global strategy of benzathine penicillin G was reported, where shortage was reported, and now WHO has recognized it as an essential medicine at high risk for stockout. Off-patent antibiotics for chlamydia, gonorrhea, and trichomoniasis may also face similar shortages in future. The trend of STIs and sexual behavior has worsened after the improvement of ART for HIV treatment and prevention. Risk compensation hypothesis and treatment optimism are phenomena that have occurred. The availability of combined ART pre and post exposure prophylaxis and treatment as prevention options have tempted more risk-taking behavior. A ray of hope in the horizon is also the STI vaccines. Vaccines against HPV and hepatitis B offer a new paradigm for STD control. We do need vaccines against HSV2, chlamydia, gonorrhea, trichomoniasis, and syphilis. Now, most STI vaccines are now being developed for early adolescents to provide maximal protection during the time of highest risk. Because the STIs tend to occur together and have overlapping complications, combination STI vaccines form an important future goal. So to conclude, action is essential to address the challenges facing the STIs globally. The problems are re-emergence of the older STIs, emergence of new STIs, long-term complications of the STIs, antimicrobial resistance, with inaccessibility of point-of-care tests and medications. All these issues are magnified in the low and middle income countries where STI and HIV care needs to be integrated in sexual health clinics. The promotion of treatment-seeking behavior and private sector involvement should be encouraged. Female-controlled methods of STI prevention like female condoms and vaginal microbiocides are needed. Development of STI vaccines is of course an absolute necessity. And to address all these issues, policymakers need to be reached out to and convinced to invest in clinical and public health strategies. Research evidence will also provide the scientific support for prioritizing interventions. So with all these methods in place, in future we can hope for a world which is going to be free of STI, and the STIs will cease to be a public health problem. Thank you so much.
Thank you, Sujata Madam, for such a crisp and informative uh, speech. Now, we'd like to start the panel discussion without wasting much time. And at the very outset, I like to welcome you all to all my respected panelists and the delegates. And I would like to thank the organizers for giving me the chance to moderate this session. My sincere apologies to all the panelists if I can't ask each of the questions to all of you due to time constraint. Now, without wasting further time, I would like to keep the ball rolling. And at the very outset, I would like to introduce my learned and eminent panelists. Is my screen visible to you all?
Yes, Shubham.
Yes.
Yes, visible. It is visible.
Am I clearly audible to all of you?
Yes, you are here.
So our topic of discussion is management of recurrent balanitis. I would like to first introduce Dr. Partha Mukherjee. And as I have already said that each one of them are well-known faces of West Bengal IDBL, and I don't want to waste much time introducing them because they are doing because every one of them are doing great in their fields. And Dr. Partha Mukherjee, he is a clinical tutor at the Department of Dermatology, College of Medicine and JNM Hospital, Kalyani. And his special areas of interest are clinical dermatology and dermatosurgery. Dr. Suchibroto Das, I was fortunate to have him as my teacher in NRS Medical College. He is currently associate professor in the Department of Dermatology, Venereology and Leprosy in NRS. His special areas of interest are psoriasis, vitiligo, and pediatric dermatology. And I have already introduced Dr. Sujata Madam. Now the next panelist is Dr. Rajesh Kumar Mondol. He is a associate professor in the Department of Dermatology in North Bengal Medical College. And last but not the least, Dr. Kinshuk Chatterjee. He is assistant professor in the School of Tropical Medicine. His areas of interest are clinical photography, dermoscopy, pigmentary disorders, etc. So, starting with the first question, I would like to ask Dr. Partha Mukherjee. I would like to start with him. How frequently do you encounter recurrent balanitis in your day-to-day clinical practice?
Right, sure. First, let me say how frequently I encounter balanitis. Usually, balanitis we see between 10 to 20% of cases. Literature also supports this. Some literature said between 5 to 10, 10 to 20, etc. I personally, in my practice, see cases of balanitis, say 1 to 2 cases out of 10 cases seen. Now, coming to the second part of your question, recurrent balanitis. Well, as such, trying to label a case of balanitis as a recurrent balanitis, there are no particular time frame guidelines, duration guidelines, or the number of episode related guidelines mentioned anywhere. If say we can say how many of those 10% of cases come to us as recurrent, we lose a lot of patients to follow up. They are happy with one particular modality of treatment, lost to follow up, do not come back in. Again, use some OTC preparations, their self-home remedies, etc. And then suddenly out of the blue, they come and say, doctor, we are again suffering. So as such, trying to quantify in percentage how frequently we encounter recurrent balanitis could be a difficult proposition to mention. But personally, I may say 1 out of 10 cases of those 10 cases of balanitis could be recurrent. Fine. That's my take on it.
Yes, sir. So my view is also that I couldn't find any strict definition of recurrent balanitis in any of the literatures. So I would like to ask Dr. Suchibroto Das the next question. What are the common causes of balanitis?
Yes, sure. There is a wide range of disease that affect the male genitalia, including inflammatory lesions, infectious etiologies, paraneoplastic, malignant conditions. However, the most common cause of balanitis are related to inadequate personal hygiene in uncircumcised males, leading to infection. We classify the conditions that affect the glands, as our topic is balanitis. And actually, glands and prepuce you can differentiate in our radiopharynx come at the same time actually. So we can classify them like infectious causes, inflammatory dermatosis, and premalignant causes. In infectious causes, commonest is Candida. It is the total among the all balanitis patients. Candida is the commonest cause. Other infections like streptococci, anoros, staphylococci, trichomonas vaginalis, sometimes herpes simplex, HPV infection like this. In inflammatory dermatosis, a group of disorders like lichen sclerosis and atropicus. In male, this classically said as BXO, Valencia obliterans, lichen planus of the glands, psoriasis and sustained balanitis, Jules balanitis like this. Eczema also is one of the very common cause allergic reactions of different external factors. Among premalignancies, Bowen's disease, erythroplasia carrate, sometimes carcinoid C2 or frank SCC we can get.
Yes.
But infection is the commonest cause.
Yes, sir. So I think anybody will agree with his views. And my next question to him is, amongst the causes discussed here, what are the conditions which may cause recurrent balanitis according to your experience?
Okay, this for me, okay.
Yes, sir. Yes, sir.
First of all, what it's told by Parthoda actually, are you sure this is a common entity? I mean, is a known entity recurrent balanitis? I don't get any clear-cut definition of recurrent balanitis like recurrent herpes progenital like that. So we can say recurrent balanitis is an entity where patients having problem of more than 2-3 times in 6 months duration or coming or almost continuous presence of the some discomfort or disorders in the that genital area maybe. And in these cases, actually, when patient coming, when giving treatment, not responding or recurrence, so infection is not a very common cause. Here, non-specific cause is the most common. Non-specific, you know, there's a term non-specific balanitis. It's the largest group actually. Almost 50% of the patients coming with recurrent causes, they are coming in this where we cannot define any cause, we cannot define anything. Patients are coming, there is a habit of cleaning the lesions of their because conserve infection of that area. And they use a multiple type of chemicals or whatever maybe at the same time, and there are some preponderance to other systemic disease childhood or in adult like this actually. So these patients have a large brunt of the number of patients actually non-specific. Other causes, specific causes, we can mention that lichen sclerosis that I mentioned in the my previous actually LP, plasma balanitis like this. These are the actually causes of recurrent and pre-malignancy. Obviously, it will come. Obviously.
So for the viewers, I have just summarized the causes of balanitis and recurrent balanitis, and according to my limited experience, I have highlighted the causes of recurrent balanitis in this table. So you can see that as sir has already discussed, candidiasis, herpes simplex, non-specific balanitis, wounds, eczema, FDR, they may be considered as the causes of recurrent balanitis. So my next question to Dr. Rajesh Kumar Mondol is that what are the causes of recurrent balanitis in children? Are there is there anything extra to add in cases of pediatric population?
Well, in pediatric population, as such, balanitis is not common. At least I have not seen much cases of balanitis in pediatric population. Whatever cases, 1 or 2 I have seen, that is due to phimosis is one cause. Congenital phimosis is one cause where there is chance of infection or accumulation of urine or fecal matter. Sometimes may cause irritation or some superadded infections like that. And one thing, atopic diathesis may cause a recurrent balanitis. Now I have not seen any single case of this in pediatric age group or adult also. This is my take.
Okay, sir. Thank you. So
one thing I want to add, just one thing, just sorry to disturb actually.
Yes, sir.
Isolated balanitis, I think it is not seen in pediatrics. It is always melanopostitis. More common is the difficult part. I think is the most common part actually. And if they need to involve the gland spines. I think my vision is that.
Yes, sir. We use the terms interchangeably in majority of the cases. That balanitis we mean as balanoposthitis here. So my next question is a case scenario. A 27-year-old male, non-diabetic, presented with repeated episodes of balanitis, which improves with topical azoles and oral fluconazole. Partner treatment was also given, but in spite of that, patient complained of recurrence. There was no history of systemic immunosuppression. ICTC was non-reactive. So my next question goes to Sujata madam. What is your
From
diagnosis in this case?
I think this is a very common scenario that we get, as Dr. Das was saying, that the patient has already applied antifungals and then come to us, and there is actually a recurrent cause of balanitis, recurrent balanitis. So this is something that we very commonly get, and here I think the point that he was mentioning, this non-specific balanitis, this comes in where you actually do not get any specific reasons, and you need to know infections and no other associated disorders, skin disorders, to explain the balanitis. And here it is often that you need to ask a proper history from the patient as to what the patient has been using on a day-to-day basis, what the patient has been applying. And these things are also sometimes even more common in patients who already have atopic dermatitis or eczema in the other parts of the ear. So the lifestyle, history regarding the lifestyle, this should be taken. And there are, there are certain predisposing factors like the poor personal hygiene, like you've put here. Yes, the long prep use, especially, I think in case of children also, this matters a lot. And the use of these OTC creams. Then here you've mentioned that the patient does not have diabetes, so I'm ruling out that. And of course, the STIs, you've just mentioned that the ICTC was negative, so I'm considering that it was not any specific STI.
Okay. My next.
I would like to stamp this as a case of non-specific balanitis.
Okay, madam. So here I have just mentioned a short slide of non-specific balanitis. We have already discussed it, that it is an unknown etiology, non-specific inflammatory symptoms, and atopic diathesis and excessive washing and poor hygiene are the possible risk factors. And the treatment is emollient, topical steroids, and topical calcineurin inhibitors. And here is a study which clearly mentions the entity non-specific balanitis and a history of atopic illness and of the practice of penile washing are important aspects in evaluation in such patients. Now, my next question to you is to Sujata madam. Would you like to perform any lab investigation in this case for confirmation? And how frequently do you do such in your clinical practice?
See, if it is recurrent, and if the patient is having a lot of problems, then maybe I could go for patch testing to see what the patient may be allergic to. Otherwise, other than trying to rule out the STIs and fungal infection, even though the patient has been using antifungals, uh, I do not think of any very important lab test that I would like to do.
Ma'am, I would
Just
like to interrupt you for a
are you asking
second.
for a biopsy, or would I like to go
No,
for a
sir.
biopsy?
No, ma'am. In cases of, if we consider the diagnosis as recurrent candidal balanitis,
Yeah.
we just treat it, diagnose and treat it on clinical grounds. So, in case of recurrent candidal balanitis, would you like to do any further lab investigation, or just plain and simple consider the other factors which may be possible for the recurrence and treat them accordingly?
Well, we can do a KOH mount and see.
Okay, ma'am. So, Madam has already discussed the factors responsible for recurrence. Now, my next question to Partho sir is that when do we suspect STI causes of recurrent balanitis? When to suspect, sir?
yes, we are gradually narrowing down of our search from infections, the non-specific etiologies to STIs. A good history period as sexually transmitted causes of balanitis and specification recurrent balanitis. So good sexual history of high risk behavior, trying to pinpoint the incubation period, and then on examination, what particular pointers or clinical pointers which we'll be seeing or expecting to see in those three principal causes of recurrent balanitis, as Dr. Das mentioned in the list and you also showed in the list. First would be, if you look at recurrent herpes balanitis, as we all know, grouped vesicular lesions on an erythematous base, they rupture to form erosions on the prepuce glands, and in a backdrop of HIV with severe immunosuppression, we may get extremely painful necrotic ulcers also, right? This is for HSV balanitis. Now moving on to Trichomonas vaginalis balanitis, here also we may get superficial erosive balanitis, which may lead to phimosis, and it has been seen that roughly between 50 to 50% of males can be asymptomatic carriers also. And partners of these males who have undiagnosed vaginal discharge, etc., you should have a strong index of suspicion here. Now, moving on from Trichomonas vaginalis balanitis to Treponema pallidum balanitis. Here, a classical Treponema pallidum may present with multiple sarcinate lesions, which may erode to from irregular ulcers, may be seen in the late primary stage or the early secondary stage. Even primary chancres may be present there. Now, I may just like to mention the Folman's balanitis, which we have read in just textbooks, a passing mention of it. But if you go through, there's a very good paper, 2016, in European Journal, right, which for the history buffs, it was in 1931, a Hungarian dermatologist, Eugene Folman, first identified and reported within the next decade 3 to 4 such cases of balanitis. What is interesting about Folman's balanitis? Presently, also this 2016 paper sheds a lot of light on it. This can have a myriad of variable presentations. What? It may present with multiple erosions, which may be painful, which may be painless. There may be ulcerations, and even in a scenario where, as Dr. Sujata was also mentioning in his presentation, now with resurgence of syphilis, we need to have a strong index of suspicion, especially multiple, painful, superficial, herpetic looking erosions. It has also been seen that point towards Treponema pallidum balanitis, whereas serology may always not be an effective guide. So dark field examination has to be needed. And this would be very important here to pin it down to a case of Treponema pallidum balanitis. Among others, a patchy erythema may be seen in HPV balanitis, and some rare, very rare causes of balanitis could be gonococcal, chlamydial, mycoplasma, but these are rare, we don't usually encounter it. So this would be in very brief, touching about on the salient features of the important causes, sexually transmitted causes of balanitis. Right, Shubhaman?
So to summarize it, sir, if we have to look for the genital ulcers or the urethral discharge, and in those cases, we may suspect the possible STI etiology.
Definitely, also. And inguinal lymphadenopathy also has to be looked into.
Also, sir. And as you mentioned clearly, which I have depicted in the slide, the myriad presentation of syphilitic balanitis of Folman's, which should have a high, we should have a high clinical, we have a high index of suspicion for diagnosing these cases. And so Kingshuk sir is not visible in my screen, so I just forgot to ask him any questions. So my next question.
I am here only, Shubhaman.
Yes, sir. Yes, sir.
Also.
Yes, sir. Yes, sir. Yes, sir. So my next case scenario is a 45-year-old uncircumcised male, diabetic, presented with complaints of persistent genital lesion for 1 year, with burning sensation and a history of mild improvement with OTC creams, which recurs again with discontinuation. He is very much anxious due to his skin condition and fearful of some malignancy. On examination, there is a well-defined bright red moist glistening patch affecting the inner prepuce and glans. Here you can see the clinical picture. Now on histology, we can see the atrophic epidermis with flattened diamond-shaped keratinocytes. Papillodermis shows band-like cellular infiltrate composed predominantly of plasma cells. So my next question to Kingshuk sir is, we are certain with the diagnosis that it may be a case of Zune balanitis. So how frequently do you encounter Zune balanitis in your clinical practice?
Well, thank you, Subhamar, first of all, for putting me in the list of questions. To say honestly, I am yet to encounter a case of Zune's balanitis which was already diagnosed. Mostly we encountered cases which were being treated or diagnosed as candidial balanitis or candidial balanoposthitis, but they were not responding to the usual antifungal treatments. And then we asked for a history, rule out all other factors predisposing to candidiasis, or take a penile biopsy, and then we confirm the diagnosis of Zune's balanitis. So Zune's balanitis for me has been a diagnosis of exclusion as far as now. And about the frequency, I don't think more than 1 to 2%.
So the next question also goes to you. What are the differentials will you consider in such a case? A persistent erythematous patch in an elderly uncircumcised male?
Well, for this case, since the patient is diabetic, definitely candidial balanitis comes first, then comes Zune. Along with that, I would like to keep erythroplasia of Queret, the in situ form of Bowen's disease, as my next diagnosis. And they are, although less likely, but there are chances of contact dermatitis, especially the patient being of sexually active group. I'd like to keep latex allergy also as my differential in the list of differentials.
And will you advise penile biopsy in such a case?
Well, honestly, I would like to do one, provided the patient agrees. Almost, I think 100% patients that refuse a penile biopsy requires a lot of counseling, and it's a very tricky situation. So if the patient agrees, definitely a biopsy will be best in this case.
So I would like to mention here, there is a clear-cut guideline mentioned in the current textbook of dermatology, Andrews, in the latest edition, that red lesions on the glands of elderly uncircumcised men when to perform biopsy. So the first criteria is the lesion should be fixed, does not move or resolve. The patient lacks other stigmata of psoriasis or another skin disease that could affect the glans penis. The patient's sexual partner has cervical dysplasia, and the lesion does not resolve with effective topical therapy for irritant balanitis, candidiasis, or psoriasis.
I'd like to just chip in,
yes,
Subhama, with one drawback with this guideline, that but it has only mentioned elderly men. The situation is little bit different in young and sexually active males, because they are very wary of the possible adverse reactions of any surgical intervention on the penile skin. May it be urethral stricture or an unsighted scar, unsightful scar, or a cosmetic apprehension maybe. So that is the problem which we have to take into.
Nowadays there is upcoming role of dermoscopy and reflectance confocal microscopy nowadays to just differentiate it from the other pre-malignant. Sujata madam, I think she has something to say. Yes, madam.
Yes, I agree with it mostly, but I think, when the patient has, most of these patients do a lot of self-medication, and when they realize that the lesion is ultimately resistant to whatever they have done, then sometimes I think, counseling in favor of a biopsy becomes a bit easier than a new case who comes and you to ask them for a biopsy. So that is what I have encountered. It's easier to counsel those patients, having a long-standing problem and who have already done self-medication.
So my next question goes to Dr. Rajesh Mondal. Sir, how to differentiate zooms from erythroplasia of Queret, and whether is there any association with zooms?
Oh, well, clinically, if you say differentiation is quite difficult with naked eye. So it is quite difficult to differentiate the both, because both presents as erythematous glistening moist red areas over the glands. But we can differentiate with some differentiation can be possible with dermoscopy examination. But in practice, I do not use dermoscope. So biopsy would be best to differentiate both the conditions. But if you ask, is there any association? There are reports of zone melanitis overlying erythroplasia of Queret overlying zone melanitis. But in my opinion, as such, there is no association. Both the entities are different. One is carcinoma in situ, and one is considered as a benign condition.
So what I have encountered, sir, through the literature search is that the case reports which have mentioned erythroplasia occurring in associated inflammatory cells in the dermis, but the textbook of Andrews, the recent edition, it clearly says that there may be variable inflammatory infiltrate present in cases of erythroplasia. So they are not a case of association, but they are a case of erythroplasia of Queret itself.
Yes.
And
Biopsy site is
one
also
thing
important.
I don't, one thing I like.
Site of biopsy is
Yes, sir?
also important, because in every field you will not get every features of both the disease.
Yes.
Absolutely.
So
And
repeated biopsy may help.
Yes.
Repeated biopsy may help. Sometimes that may happen that in first biopsy you will get features of not that of carcinoma in situ, but in repeat biopsy you can get the features of carcinoma in situ. So that may happen.
And I'd like to add to what Rajesh
Yes.
said, serial sections might help in these cases.
Okay.
Along with repeated biopsy, the serial section will help.
Yes, yes. That's what
a clinical pointer would be induration of the lesion.
Yes.
And indurated lesion is very suggestive of looking at erythroplasia of Queret, right?
Yes, sir. And erythroplasia lesions are, I think they are plaque lesions, and Bowen's disease lesions are patchy lesions. So
that's
that
what
may be a clinical, yes.
Indurated lesions.
And my next question to Rajesh sir is that zone balanitis truly benign?
Well, it is considered as benign, but there are reports of conversion to malignancy also. But it is considered, in general, it is considered as a benign condition.
Yes, sir. There are 2 case reports where carcinoma of penis has occurred in case of long-standing cases of Zuhn's balanitis, where the patient was lost in follow-up and he just presented with a indurated plaque overlying a previous lesion of Zuhn's balanitis, and histopathology was done. We showed a frank case of moderately differentiated squamous cell carcinoma. So, my next question to Kingshuk sir is, why do we at all need to manage a case of recurrent balanitis?
I think because it is a very frustrating condition. For men, it is a very important organ, and resistance or recalcitrance to treatment makes it vulnerable. And as we have rightly seen, that an untreated case of seemingly benign Zuhn's balanitis may turn into malignancy. So we need to catch them early.
So the principles of management, which have already been discussed, is to minimize the sexual dysfunction, to minimize the urinary dysfunction, to exclude penile cancer, to treat pre-malignant disease, and to
Shubham, you are not audible.
So we can hear Shubham.
Shubham, you are not audible.
So we can hear Shubham.
So we can hear Shubham.
Okay,
Yes, we can.
now it's clear. Sorry, I was not picking up.
So my next question is to Kingshuk sir is as well, that
Yes.
how to manage a case of recurrent balanitis?
by management, if you, I think investigation part, there is not much to discuss, already been discussed. So first and foremost is counseling, definitely. Counseling helps not only to rule out the differentials, but also to ensure a compliance from the patient, which is very important in terms of treating a case of recurrent balanitis, because as we have already discussed, the patient has already tried multiple things. And the treatments which we are going to prescribe might be a bit of repetitions of already he has used. So we need to counsel them about the appropriate dosage and duration of treatment. Second part is definitely the need of biopsy, as Sujata ma'am has already nicely elaborated. These patients are easier to counsel on the biopsy part of the treatment. Apart from general measures of hygiene, we need to examine that if there is any anatomical abnormality involving the foreskin. Partner management is very important. The perils of self-medication have to be discussed well with the patient. Possible use of any irritant has to be avoided. In our country, most of the people are using Dettol and Savlon and all those soaps which containing alcohol. They are a common cause of common perpetrators of irritant in an already inflamed lesion. And then if there is a known case of latex allergy or the latex is aggravating the inflammation, then it needs to be avoided.
Okay, sir. So now now coming to the specific measures that recurrent balanitis should be managed. First, there was general measures have been discussed, and specific measures are according to the etiology. Here, one thing which I need to discuss with all of you is that in cases of recurrent herpes, we all know that if there are greater than 6 episodes per year, we administer suppressive therapy in those cases. So what is the dose and for how long do you continue acyclovir? So starting with Partho sir.
My take would be acyclovir 400 milligram twice daily for a year at least. Very simple. I keep it simple.
Okay, sir.
Other panelists may have their own opinions.
Okay, so Dr. Shuchibrata Das.
I usually what I do, I advise the patient to continue. Definitely, it is acyclovir the first choice. 400 milligram twice daily. I usually give for 6 months. I advise the patient to continue for 6 months and give a break. If again there is recurrence and again at the same like previously, then I told the patient you have to continue this. You have to continue.
So there is no clear-cut guidelines, sir, mentioning that for how long we have to continue. Dr. Sujata, madam, do you have anything to add here?
No, just to add that studies which have been done regarding the suppressive measures, the range is from 1 year to 5 years. So they've evaluated till 5 years, and they have found that the incidence of relapse after 5 years of therapy has actually been even less than 1%. So personally, I would definitely use from any time between 6 months to 1 year. But there is no clear cut. There is definitely no clear cut indication that you need to suppressive therapies for so and so years. It depends on the patient response, I think.
Dr. Rajesh sir and Dr. Kinshuk sir, do you have anything to add to this?
Minimum is 6 months. Then you can prolong it for 1 year also. Minimum is 6 months.
Okay. So we have a.
I'd also like to continue for 1 year with a 6 monthly follow-up.
Okay, so the clear-cut consensus here is that we have to continue for at least 1 year, 400 milligram BD. And coming to the next question, that will you advise circumcision and when in cases of recurrent balanitis? The question goes to Dr. Partho sir.
Circumcision definitely, as other panelists have also mentioned, Kinshuk was also mentioning, in refractory cases where the patients are having problem for quite a long time, coming back to you frequently, definitely circumcision, number one. Second, why circumcision? To secure your sexual future, to reduce incidence of sexually transmitted infections in the era of HIV, that is also very important, and then to decrease the incidence of these pre-malignant and malignant conditions we have talked about. So if you can counsel the patient regarding, as in zoons, circumcision is now the first line of management. It's documented everywhere. So if you can counsel the patient regarding the importance of circumcision and cajole the patient or do whatever you like to ask the patient to go for circumcision, that would be, and that would decrease the incidence of penile carcinoma by 3.8-fold. I feel the literature I read somewhere shows the incidence like this. So it's a boon, obviously, as a form of treatment, circumcision, right? This is my comments on it.
Dr. Kinshuk Chatterjee, do you have anything?
Yes, I agree with Parthosa. Circumcision has specific indications in case of recurrent balanitis. Like I've already mentioned.
Any specific case would you like to add, or in cases of
treatment
recurrent
refractory cases and those who are specifically where we suspect a case of pre-malignant changes like erythroplasia of Queret, in those cases definitely, because nothing else will work. Bifluorouracil has very limited role and there are very few studies supporting the efficacy.
Okay. So, and the last question goes to Dr. Shuchibrata Das. What complications do you see in a case of recurrent balanitis?
Complications actually is already here. Due to chronicity, there is chance of conversion to malignancies. Though I didn't see a lot of that type of patients, but I think that is one serious complication. Others is mental anxiety is very important for this age group of patients. Actually, all the patients are so anxious that they're doing doctor hopping. Actually, they're coming for a few days or few weeks in my chamber, going to OS chamber, then Parthosa's chamber, like this. In a year, they covered all the chambers surrounding. It's very important to convince the patient that it is not serious or this is serious, and we have to take this measure. We don't need to do anything. This is important very much actually. So these are the complications actually. Yeah,
okay.
You mentioned that these are thymosis, definitely these are long-term complications. The repeat infection due to all definitely.
Okay, sir.
And scarring can be added to the list.
Absolutely. Meatal stenosis.
Yes, so I think we have overshoot the time and we have completed all the things. My take-home messages are balanitis is a fairly common disease. Candidiasis, non-specific balanitis, herpes, FDR, zooms, they are the commonly encountered cases of recurrent balanitis. We have to exclude STIs in patients with suggestive history. And in elderly uncircumcised patients presenting with persistent erythematous patch over glands, biopsy and regular follow-up is mandatory. And circumcision may be considered as a therapeutic option in recalcitrant balanoposthitis. So with this, we come to the end of this panel discussion. And a lot of thanks and heartfelt thanks to all my panelists, which have helped this panel discussion. And I cannot thank you more. Thank you very much.
Thank you,
Thank you to our all esteemed panelists and for the moderator for this wonderful enlightening session.